Good evening. I'm seeing some new faces in the audience tonight. First, I'll introduce myself before introducing our speaker. I'm Dr. Stuart Drescher. I'm a psychologist in town and have been on the board of OFFER since its inception 10 or 11 years ago. And we hold these meetings once a month, the first Wednesday of each month, to provide information and support for people who have these illnesses. And there's nothing like having a famous speaker to swell the numbers of people attending. I'm glad to see a good turnout tonight, and I think you'll be rewarded with some rich information. So without further ado, Dr. Bateman is going to update us on what's been happening in research and practice in chronic fatigue and fibromyalgia.
This is kind of an interesting talk because, and I think Stuart gave his talk on an earlier meeting, but we had a conference for mental health providers, specifically to try to help them understand about how to help people who have pain and fatigue. And to understand that there are many dimensions of those symptoms, and it's not just cookbook. And I think sometimes mental health providers shy away from those symptoms because they don't understand them, they don't know how to approach them. And other times they oversimplify them and think that they're all related to a mental health problem. And those problems have created some bumps in the road for people who try to access help from mental health providers. So this conference was designed to bring experts together in the field of mental health and the medical aspects of pain and fatigue, and my talk was on fatigue. So we decided to share that talk with you today, a little bit more angled toward the patient audience, but you can think about that while we're talking about it. And it's not really a talk just about chronic fatigue syndrome or fibromyalgia, but to take a step back and think about fatigue in general and some of the challenges of trying to help people who have fatigue. Figure out which buttons to push here. So I think that we could probably entertain some questions along the way if you want, because really this is just for you. This is a chance to think a little bit about fatigue. And if you've got questions while we're going along, I think that's okay with me if we stop. But we'll also take the time at the end, whatever time we need to. And I'm sorry I didn't bring a handout, but I just wasn't organized enough to get them all printed off. It's also a little bit difficult to know how many handouts to bring to something like this, and it's kind of long handout. So we should have access to, you should have access to the information on our website. Once we get it up online, you can view it again. If you really want a copy of the PowerPoint slides, just call my office and we'll email them to you. Because that's easy enough to do, and it's a lot cheaper than printing out a bunch of copies. Then you can print it out any size you want. So why should we pay attention to fatigue? And remember, this is a question that I asked mental health providers. I think it's evident when you're the one with the fatigue that the fatigue's really getting in your way, but fatigue has traditionally been a little bit overlooked by both mental health and medical providers. Now, some people aren't aware that fatigue is the most common complaint that goes to a primary care office, just fatigue. It's also a primary symptom of almost every mental health disorder, fatigue. The fatigue can be curable or treatable, so you'd hate to not pay attention to it, right? It's something you can completely fix. That's a very important reason to address and understand fatigue. The fatigue may not be curable, it may be disabling, and it causes a great deal of emotional distress to deal with that kind of fatigue. And that's another really, really important reason to have it assessed and have particularly mental health providers understand the toll it takes on a patient to deal with severe fatigue. So medical and mental health therapies play an important role in all kinds of fatigue. Reversible fatigue, treatable fatigue, and incurable fatigue states. All very, very important. This is my dog, Wolf. And I don't know if you can see, he's had a long day, and he's got a paw on the bone and a paw on the ball, and his ears are back, and look at his back legs flipped over. He's like completely relaxed and exhausted. I know, don't you feel that way? I had to put a picture. So fatigue can have many, many causes, even in one person. And that's one thing that makes it challenging. It is difficult to communicate what fatigue feels like. Have you ever tried to explain it to someone? What it feels like to be burdened by fatigue? The fatigue severity may be difficult to assess and measure for your providers. That is the main reason it blows by. I think that I'm actually very shocked sometimes that my patients go see doctors and they never have any idea how disabled they are by their fatigue. That it just doesn't, it never logs in. And it's because it's difficult to communicate. We don't have ways to measure it. And unless you spend quite a bit of time or unless you know how to communicate about it to your either mental health provider or medical provider, they just don't get it. So that difficulty in communication is a huge barrier, and the inability to assess and measure it. And the impact on function is relevant and important because I say sometimes there's fatigue and fatigue and fatigue. When people make jokes about fatigue, that's still fatigue. People like me who have a lot of energy still get tired at the end of a long day. But that fatigue does not stop me from coming and giving a talk tonight, right? I can sort of eat a donut. We were talking about eating a donut and hydrate and come and push through the fatigue, and there will be no cost for me. That is still fatigue, but it's a fatigue that does not really impact my function. And then on the other end of the spectrum are levels of fatigue that make it so people can't get up out of bed. I know people that relapse so severely, they literally cannot lift themselves out of the bed. Just talking to a patient yesterday who went with her family to Disneyland, which was a little much. She tried to do all the things she could, the wheelchair, come all over the room. By the end of the week, she had to stay home. They drove both ways. She rested for a day, and on the day after she got that, she went to the store. And it was the first time she'd ever gone to the grocery store and wasn't able to make it home. She did her shopping. She should have left her cart when she realized she was getting tired. But by the time she got to the cash register, she couldn't get her groceries onto the conveyor belt, and she just sank down onto the floor in the grocery store, and they had to help her. And she just really didn't realize the impact of that fatigue on her function. And unless you understand more about these illnesses, you just can't possibly understand that. So being able to convey how fatigue affects function is very, very relevant and important to trying to sort through the different causes of fatigue. So there's so many kinds of fatigue that we're going to actually leave a few out. Still going to leave a big plate. One of the ones we're not going to talk about is the type I was telling you that I experienced coming doing this tonight, and that's just fatigue that comes from excess mental or physical activity. So when people have had a long day, or they've had long days in a row, or they've been working too hard and they need a vacation, and they take some time off and they recover, that's acute fatigue, that's ordinary fatigue. We're not going to talk about that tonight. There are people who could take care of that fatigue. Sometimes we ignore it, and then it leads to other things. We're also not going to talk much about somnolence or sleepiness. But this is important, actually, in the workup of fatigue, so don't forget about it, because if you have an overlay of somnolence or sleepiness, there's usually another cause for that. And the causes for sleepiness during the day usually have something to do with disordered sleep or sleep deprivation and sedating drugs. Those are my two most common things that cause daytime sleepiness. Something that makes it so you don't get enough sleep, or a medication that makes you sleepy. And then occasionally acute illness will make you sleepy. Like when you have the flu, or you're really sick and you just need to sleep and heal. We're not going to talk about that kind of fatigue today either, although it may cross our paths. So this is what we're going to talk about. And I don't know how well you can read all that up there. We're going to take a little bit of time and look at this. But I tried to write down some major categories of fatigue just to get people thinking how common it is and how it crosses over so many boundaries. So look on the far right side under medical illness. I've just grouped them in categories, but many, many types of medical illness cause very significant fatigue. Neurologic issues like multiple sclerosis, Parkinson's disease, sleep apnea, Those kinds of fatigue, and I put stimulant withdrawal, that's kind of a neurologic, pharmacologic fatigue. Certainly people who have cancer have fatigue, not only when they have their cancer, but sometimes certainly during their treatment. Sometimes they stay tired after the treatment. Autoimmune diseases cause fatigue. Chronic infections cause fatigue. Like sinusitis, there's some articles that show that some people who think they have chronic fatigue really just have a chronic infection. When they finally locate that infection and treat it, the fatigue resolves. So, and a smoldering, undiagnosed infection can give you fatigue. Certain kinds of heart disease, someone who has congestive heart failure or inadequate pump can feel very tired, have low stamina. Metabolic problems like anemia, vitamin deficiencies, low oxygen, certainly hormone problems, we're all familiar with that, like hypothyroidism. Menopause is associated with fatigue when women lose their hormones. Actually, men get fatigue from low testosterone. And then there are many medications that contribute to fatigue. So there's a big list of medical problems that contribute to fatigue. That's step one when someone with fatigue goes to the doctor. You go to your primary care doctor, you go to a specialist, they run some blood tests, they take a history, and hopefully those are really not too difficult to find. Sometimes it takes a little deeper digging to come up with those diagnoses, but for the most part, your primary care doctor, the specialist you see will be able to sort through those. Those things can happen to people with other types of fatigue, maybe from chronic fatigue syndrome. So that adds an overlay of fatigue on top of the fatigue from the first problem. At the bottom of that list, I put fibromyalgia and chronic fatigue syndrome because I think a lot of physicians don't really consider them a medical problem, don't really understand where they fit in. But the more we know about these illnesses, the more we know they are very physiologic, important medical problems. And fibromyalgia is a central sensitivity syndrome that causes hyperalgesia or amplified pain. And that amplified pain all over the body is what characterizes fibromyalgia. And the term chronic fatigue syndrome, people who are described by that syndrome, diagnosis, we're going to talk about it, have central nervous system issues. HPA means hypothalamic pituitary adrenal issues, and they may have chronic infection, features of autoimmune disease, and autonomic nervous system dysregulation, so it's a real complex illness. But I still place those over there, but then we're going to take a little more time to talk about them. So let's look at the box, the green box, age-related fatigue. This is important. As we age, we really just don't have as much stamina. And that is true starting from youth all the way up. And I've had people who've been sick with something for 5 years and tend to recover, but they never get back to the way they were. And some of that's just because they're older. And you've got some mileage on you, and the stamina is not there. So it's something to factor in when you're trying to understand about stamina fatigue. You do just have to kind of slow down, take things a little easier as you age. If you look up in the top box, these are kind of ill-defined issues, but they're very important. So you have things you really need to think about that sometimes people don't think about. Medications can contribute to fatigue. Deconditioning, that just means your body gets weak, your heart muscle gets weak, your muscles are weak, and that is fatiguing. Have you ever seen somebody who's been in bed for a long time and their illness is better? They can barely walk. And they have to start at the bottom and start taking a few steps and a little bit more. That's why we put people in physical therapy. So deconditioning accompanies chronic illnesses, and it's very profound. So when we talk about deconditioning in people who have chronic fatigue syndrome or fibromyalgia, it's not a flippant thought. It's a very important part of improving a reversible or a part of the fatigue that's in our control. Not always that easy, but it is a part of it. So being stressed, overextended, and run down causes fatigue. It's a little bit of that acute fatigue we talked about, but sometimes it's so chronic that we might take a long time to catch up and get better. Poor sleep. HPA axis dysregulation is kind of a general term. You've heard of adrenal fatigue. And when people are stressed, those signals from the brain affect the hypothalamus and the pituitary, which in turn affects all of your organs. And it's like when young women are starting their period and then they'll travel, do something, and their period will stop. That's a little bit of HPA axis dysregulation. So stressors and things you do can alter the normal way your hormones function that doesn't really fall into a disease category, I guess is why it's up here. Poor nutrition definitely can alter your stamina and fatigue. And I put pain up there because pain isn't really a disease, but pain can cause fatigue. Pain is a big contributor to fatigue. And then on the far side are mental health disorders. And a grief response can cause devastating fatigue. Have you ever been around someone who has lost their spouse or a child? Sometimes their health just takes a terrific dive, and they're just hardly able to do anything. It's not really depression. It's grief. It's profound. It's like a profound event. It's kind of linked to depression, and all types of depression are associated with fatigue. Anxiety is associated with fatigue. Anxiety is very, very exhausting. The body never rests, doesn't sleep, and it gets into a very fatigued state. Bipolar disorder has a profound fatigue. I've seen people on the ups and downs of bipolar disorder be bedridden by fatigue from bipolar disorder. Certainly psychotic illnesses can have severe fatigue, alcohol and drug abuse, eating disorders. So you can see that there are many, many dimensions to fatigue. And when we were preparing this talk, Dr. Lee Smith said, well, what % of fatigue that walks into the doctor's office is chronic fatigue syndrome? And I said, I don't know. How do we know? Because we can make the diagnosis of chronic fatigue syndrome, but an overlay on that are all these other confounding variables of fatigue, so it's hard to know exactly how to count the number. And what % of fatigue is mental health versus medical disease? Well, I don't think they very often appear in isolation. They tend to occur together very, very often. So it becomes a challenge when you're working on your own health or when a medical provider or a mental health provider is trying to help you to sort of tease through what part of your fatigue comes from the depression and what part comes from the medical illness. There isn't a litmus test for that. So some of the nuances we're going to talk about today will talk about how you might be able to, along with your health providers, sort through the aspects of your fatigue until you get better at understanding how to deal with it. So just to remind us, fibromyalgia syndrome is defined by chronic, widespread pain and tenderness. That means has to be present for more than 3 months, has to be all over your body, and you're tender. The skin is tender, and the doctors do a tender point exam to make that diagnosis. And it's really characterized by amplified pain signaling in the nervous system. Everything's ramped up. And we can measure this physiologically. You can measure increased pain neurotransmitters in the spinal fluid. You can image the pain processing centers in the brain. We know that this is the case. It's also characterized by fatigue, cognitive symptoms. I think of it as mental fatigue that goes with fibromyalgia, and disturbed sleep. We don't exactly understand what exactly what all the primary issues are with fibromyalgia, but there's definitely a syndrome that develops that's very consistent and very common. I also think people develop fibromyalgia on top of other illnesses when that illness is stressful and difficult. But I really see that development of widespread pain as being related to chronic, unrelenting stressors on the body in very, very many people. A lot of times I see a young person who gets chronic fatigue syndrome or post-viral fatigue, they don't have much pain, but as they live with their illness and encounter day-to-day stresses, they feel horrible, they don't sleep well, they're struggling, they gradually start to develop more widespread pain. Exactly what the cause is, I don't know, but those relationships are there. So fibromyalgia syndrome isn't just one thing, but it's definitely a pattern of upregulation of all those pain pathways neurologically. We define chronic fatigue syndrome by case definition. There are a couple of them we're going to talk about. The 1994 paper that was the author was Fukuda is the common one we use in research. And in order to meet these criteria, a person has to have unexplained chronic fatigue. So it has to be evaluated, and all those medical problems you saw in that big list should be ruled out as the causes of the fatigue. And it needs to reduce function. So it's not just the fatigue that's ever there. It really needs to be the kind that makes it so the function is not normal. And then people to meet the criteria have to have at least 4 of those 8 symptoms. And I color-coded them because I think post-exertional malaise is an important symptom of what I would call chronic fatigue syndrome. I think it should be elevated to the primary symptoms. And if you notice, those red symptoms look a lot like fibromyalgia symptoms. So it's their pain and sleep problems and cognitive issues. And then we also tag in there the infectious symptoms, sore throats and tender lymph nodes. So this probably isn't one thing either, but we group everyone together who meets all the same criteria. And we're trying to understand chronic fatigue syndrome. And any given patient can have enough pain to meet the fibro criteria and enough debilitation and fatigue to meet the CFS criteria. So they're not really mutually exclusive. They're just describing the nature and severity of the symptoms. This is the Canadian case definition. It was published in 2003. Pretty similar. A little bit different arrangement, a little bit more clinically friendly. The fatigue has to reduce activity, it needs to be unexplained. It must be characterized by post-exertional malaise or post-exertional pain. And then sleep dysfunction, some types of pain, neurocognitive symptoms must be present. And then one symptom from at least 2 of the following, some autonomic symptoms, neuroendocrine symptoms, and immune manifestations, and it needs to be chronic as well. So this is just another way that was devised by another group of people to try to describe what we see in people that have chronic fatigue syndrome. But remember that someone with fibromyalgia chronic fatigue syndrome can have the mood symptoms, overlay, anxiety, depression, and they can have medical problems, and I frequently see that in my clinic, diabetes and hypothyroidism and sleep apnea on top of what we're dealing with the primary problem. So all those things layer together to contribute to the fatigue. So if you use the Fukuda criteria, that 1994, the first CFS criteria, the CDC has done some estimates doing random digit dialing and bringing people in for evaluations to try to decide how common it is, how prevalent is this type of illness. And they're very strict in this, that they have to be people without other conditions along with their CFS, carefully evaluated. And they did 2 big studies. One was done in Wichita, Kansas, and one was done in Georgia. And in the study in Wichita, they estimated that there were probably at least 1 million people in the U.S. who met those criteria, and double that number that had those symptoms, but when we brought them into the clinic, they found other contributing causes to their fatigue. So they're equally sick, but they found more reversible causes or other contributing factors to their fatigue that were a little bit more treatable. In the Georgia study, they designed it a little bit differently, and when the results came out, the prevalence was 4 times higher, and they estimated there were at least 4 million people in the U.S., and almost double that number that seemed to meet the criteria over the phone. So this doesn't exclude fibromyalgia. These would be people who have pain or no pain, but they have severe limiting fatigue and no other explanation for their fatigue. So this is a really significant public health problem. And what was devastating, really, was that more than 80% of the people they reached had never been diagnosed with chronic fatigue syndrome. And many of them had not even seen medical providers. So how expensive is something like chronic fatigue? Now remember, this is leaving out all the other causes of fatigue that walk into the doctor's office. Just chronic fatigue syndrome, the Georgia study estimated that in Georgia there were $1.65 billion per year. If you count healthcare expenses and lost productivity, that means the loss of not being able to go to work and earn money, bring money into your family. I mean, enormous health costs in our country. Older study estimated that indirect and direct costs were up to $24 billion per year in the country, which might be about half as much as that second study estimated. And that's because the Georgia study found a lot more people. So this is a huge public health problem. And I really put this in to convince the mental health providers in our talk that this is important. It's worth the time of all medical and mental health providers to understand about these illnesses so that we can all work together to provide supportive care. So what causes chronic fatigue syndrome? Well, unfortunately, we really don't know exactly what causes it in terms of a single, simple explanation. But there are many studies that show that people can develop chronic fatigue syndrome after an infection, and not just one infection. But this was a study done in the U.S. first I'll tell you about one done in Australia, and they looked at 3 different kinds of infections: Epstein-Barr virus infection, Ross River virus infection, and Q fever. These are really common infections in Australia. And they enrolled people in the study when they became first ill with those infections. Not when they had chronic fatigue syndrome, when they just got the acute infection. And then they tracked them. And at the 1-year mark after those infections, 11% of people who had those infections met the chronic fatigue syndrome criteria. So many different infections can leave people with chronic fatigue. Now, a study that we did in the US, not that long ago, this was published in 2009, enrolled young people who developed mononucleosis in a study. And they enrolled 301 young people who got mono, caused by Epstein-Barr virus. Big spleen, big liver, sore throat, tired, can't go to school. And the dogma about mono is, you'll be sick for 4 to 6 weeks and then you get back to school, right? Well, in this study, they discovered 6 months after that acute infection, 13% met criteria for chronic fatigue syndrome. 12 months after the infection, it was down a little bit, but 7% were still sick 1 year after the mono. And 2 years afterwards, 4% still met criteria for chronic fatigue syndrome. Well, virtually every adult is exposed to Epstein-Barr virus infection by the time you're an adult. You may not develop severe mononucleosis, but it's a very common infection. And lots of people don't really fully recover after Epstein-Barr virus infection. And we know that a syndrome like chronic fatigue syndrome can come from not only Epstein-Barr virus, but cytomegalovirus, HHV6, West Nile virus. I have 2 patients in my clinic that had well-documented West Nile virus and went on to have very severe symptoms after the infection had resolved. Parvovirus can leave people with a chronic infection, and there are probably others. So we know that viral infections play a role in the onset of disease in at least some people with chronic fatigue syndrome. What exactly happens to cause chronic illness, we don't really know. We don't know. We've never been able to prove that the infection is still present and active. There's a hint that the viruses may reactivate. That's hard to prove, actually. I know it's true in some cases, but it's hard to prove in all cases of chronic fatigue syndrome. And there's more and more evidence that there may be a chronic autoimmune or immune response perpetuating the illness, or maybe a little bit of all those things. But we still are unable to provide a diagnostic test in the clinic that can make a diagnosis. In fact, if you took any of those kids with mononucleosis and brought them into the clinic a year later or 2 years later, there would be no test you could do to show what had made them sick. The only reason they knew what caused it was because they enrolled them when they got sick. You can do the tests right at the time they're sick, but the tests are not a diagnostic after they've been sick for 2 years. That's why you can't just order EBV titers and look at old titers to know what caused your illness, because you keep those antibodies the rest of your life after being exposed to things. Everyone does. They're a sign of your immunity, right? So they're a good thing to have antibody titers. So it becomes difficult to know how to interpret them. So I wanted to bring to the attention of the providers that we at least have quite a bit of information about post-viral syndromes. Even though we can't use it in an individual, we know what happens, and we know that probably many people out with their chronic fatigue syndrome had some kind of a viral illness that triggered their syndrome. But we also know that abnormal circulation, blood volume, and autonomic regulation may be present in people with chronic fatigue syndrome. And this started in 1995 with a study of tilt table testing done by Dr. Peter Rowe at Johns Hopkins. And virtually everyone they looked at in their first studies had abnormal tilt table tests. And they published that, and there was a big wave. And since then, there's been a lot of controversy over exactly how to measure it and if it's present in everybody. And these terms cropped up: orthostatic intolerance, neurally mediated hypotension, and POTS, postural orthostatic tachycardia syndrome. They're all part of a family of illnesses where people can't maintain a normal blood volume and blood pressure. When they stand up, their blood pressure drops down, their heart races, they don't get good blood flow to their brain. And there have been some pretty good studies in the last couple of years to demonstrate this. This is the picture of someone lying on a table and then having the table come up. They strap them in so if they faint, they don't fall off that table. And you could measure blood flow and transcranial Doppler, and I want to show you what one of these studies showed. These were kids with POTS, that's postural orthostatic tachycardia syndrome. That means their heart races when they stand up because their blood pressure drops down. And I just want to show you with this diagram. So the top pictures are the normal people, and the bottom pictures are the patients with CFS and POTS. And those red lines are when they tilt the table up and bring the table back down. And you can just run the lines down all the way to the second diagram. So if you look at the first set of diagrams on the left, you'll see that the normal person, when the table tilts up and comes back down, there's not much change in their heart rate. You see that? The lines just go across. But if you look down to the POTS, you can see that the minute the table tilts, the heart rate jumps up and stays up until the table comes down, and then it comes down again. If you look in the middle, this is what happens to their breathing, and there's nothing that happens to the breathing in the normal people, but the people with POTS get very chaotic breathing and distress during the tilt. And the last one shows their carbon dioxide levels. The people with POTS, their carbon dioxide levels go down and down and down. They hyperventilate, and it makes them feel very sick. They hyperventilate because of these blood shifts and feeling very uncomfortable. And then that breathing causes additional bad symptoms. I'm not talking about hyperventilation, a neurotic type of hyperventilation. I'm saying it's part of the physiology, and it makes them very ill during the tilt. And if you look at where the blood goes on this graph, so this is during the tilt, and the white bars are where the blood goes in normal people, and the red bars are where it goes in the patients. There's a loss of blood from the chest that's very accentuated in the patients. Do you see that? There's a really big loss of blood volume from the chest. And where does it go? It goes down into the abdomen. Splanchna means down where your guts are. So when they stand up, their blood volume and other fluid volume just drops with gravity, and it makes their chest feel very abnormal, which causes that breathing, that distress. So their heart races, their blood pressure goes down, and they have these big shifts. That's orthostatic intolerance, and you can measure it. And that is very difficult. During these same tests, they measured blood flow in the brain. And the top graph is their mean arterial pressure. They looked in one of the arteries in the brain. And I don't think the arrows are the beginning and the end of the tilt of the table. And the black lines are the normal people, and the gray lines are the patients. So you can see as soon as the tilt goes up, they get a drop in the blood pressure, or in the arterial pressure in their brain. And the bottom one is blood flow, not pressure, but flow. The minute the tilt goes, blood flow drops down in the brain and stays down until they end the tilt. So we know that people who have orthostatic intolerance have a lot of things that happen physiologically in their body that can contribute to fatigue, least of which is a change in the blood flow in your brain that adds to headaches and thinking, unclear thinking. It can cause irritable bowel symptoms, abdominal pain, and abnormal chest symptoms and dizziness and all kinds of things. Most people don't usually faint, actually, with orthostatic intolerance. They just feel ill and they don't know why. But this has been studied, and we have quite a bit of evidence to support it. So those were just two examples of some of the physiology we track in patients with chronic fatigue syndrome. And this is just a list of the flavor of what I see in my clinic, different groups of people who come in. You can see where you think you fit in here. Of people who have unexplained chronic fatigue. And when I say that term, I mean they don't have another known medical illness to explain their fatigue. It's not part of a mental illness. It's not part of a known medical illness, but they fit under the categories of CFS and fibromyalgia. And the first group are that post-viral fatigue, so people who have a known virus and go on to have POTS, and this is really common in adolescents. This is one of the most common presentations of kids in their teens and sometimes in the 20s. They don't have a lot of pain usually. Then there's another really devastating syndrome of a flu-like onset that's just dramatic, and it usually happens in middle age. We think of it as viral. We don't actually know what happened, just some dramatic illness, and people are severely impaired by CFS, we call it. And I think this is more often what we call ME/CFS, or myalgic encephalomyelitis. There are people who have gradual onset following weeks to months of stressful circumstances, often pain predominant. They often have things going on, sleep problems, hormone problems, and they may have a lot of mood symptoms. And that's kind of typical for fibromyalgia. It comes on more gradually. People are very stressed over time, sleep deprived, and they get more stiff and more fatigued and more pain. And those pain pathways ramp up and stay there. But they also have an important component of fatigue. Sometimes people have a real dramatic, complex hospitalization. they get in a car accident or they have a really complicated experience, like being diagnosed with cancer, being terrified, undergoing surgery, having chemotherapy, and when you come out on the other end, you're cured, but you're impaired and ill with chronic fatigue. There's a fatigue that comes with anxiety. I talked about that, and with bipolar disorder. And there are mixed in, I think, people who have another disorder, but it's not clear enough to make a diagnosis. Like someone with MS who doesn't meet all the MS criteria. They might have MS, they might have symptoms for 10 years before you're able to make a diagnosis of MS based on the usual parameters. And same with autoimmune diseases, and sometimes it's really difficult to make a diagnosis of certain kinds of hormone disorders. So, and then on top of it, I have people who just have too much going on. It's hard to tease through what's going on with them. They've got diabetes and asthma and other pain problems, and they're depressed, and on top of it. So it can be very, very complicated. And I think, you have maybe you've seen people or known other people and kind of see how they niche. They're all important. They're all equally disabling and troubling for whoever it is that develops them. So how do we assess fatigue? It's a challenge. I think it's really important to just have very good communication. How long do you have to talk when you go into a doctor's office? Like 3 minutes, 5 minutes? It's really very difficult to have a conversation about fatigue. I think in a mental health provider's office, sometimes it's one of the best things about it, right? Going and see a therapist, you can spend a lot more time talking about the dementias of the fatigue and how it's affecting you. But then they're not the medical person to help tease through the diagnosis, but they can help tease through some of the other aspects of it. So we use numeric rating scales. That's just, we'll go through some of these. You can use standardized tests. I have a new measurement I call hours of upright activity for people who have come to my office. It's just literally how much time people can stay on their feet. I think it's become a very, very good measure of illness. And patients with fibromyalgia do a lot better than people with CFS. Patients with fibromyalgia feel horrible, but they can generally put in, 8 to 10 hours. They're really exhausted when they get done. They're usually just barely able to maintain full employment at a cost. And then I have people with CFS whose total hours of upright activity during the day is 2 to 4 hours out of 24 hours. That's about it, the amount of time they can do something with their feet on the floor. That's profound. And there's a big spectrum. But that's been one of my best communication tools, is having people tell me where they fall on that scale. It helps me understand much better about their function. I think that this is highly underappreciated by other people, other medical professionals and mental health professionals, but the responsive fatigue to exercise is very, very important diagnostic tool for me. People with mental health, any of us with depression or anxiety or other mental health conditions, that kind of fatigue does a little better when you exercise. Get out, go on a walk, start to get more fit. All of those things are improved by exercise. Even fibromyalgia, just pure fibromyalgia without an overlay of chronic fatigue syndrome, there's a lot of data to show that low impact exercise and weight training, and the better fit you are, the better you manage the fibromyalgia. It may be more painful and more difficult to do it, but people gradually improve the more fit they are. On the other hand, there are people who absolutely have to be careful about how much activity they do. And if they do more than their body will tolerate, they become much more ill. Now, that's true with fibro, too. I'm not saying these are mutually exclusive. People with fibromyalgia be very careful because their activity will flare their pain and really flare them. But there's another group of people with severe CFS. I mean, I was talking to someone in my office today, and I can't do 3 half-hour activities in a day. If he does, or if he does them 2 days in a row, he's down. It varies through the course of illness. So anyway, that fatigue response to exercise really helps me understand. And I think what I counsel my patients is to gradually try to develop better fitness. And it helps you learn more about your own illness. And if you can gradually become as conditioned as possible, it's going to be to your advantage. But you have to learn how to listen to your body and know when to pull back and when to stop if that activity is going to make your disease or illness worse. And then also how the fatigue responds to treatment. Other kinds of treatment help you. Some fibromyalgia patients, if I get them on the right medications, they're good to go. Treat the pain, treat the sleep, get a few things on board, they can go live pretty normal lives. Plenty of people who respond well. It's not true, uniformly, but fibromyalgia, if it's mostly sensory, if it's mostly about pain, when you treat the pain, the fatigue gets better, and you can treat all the aspects, and patching those things up will make the fatigue much, much better. And there are other people that I would put more on the chronic fatigue syndrome pot. Sometimes the more you mess with it, the worse it gets. The more medications you try, the more symptoms get worse, and so you have to be very, very careful and not put everybody in one bin. So these are numeric scales that just help you communicate pain. We use this in my office every single visit, so I can just, at a glance, understand where people are on the severity of their symptoms. And my goal is to kind of, usually when I first meet someone, they're all up in the 8, 9, 10 range. And my goal in treatment is to get them all down below the midline. So if I can get everything 5 or below, then we're doing great. Most people who rank their symptoms 5 or below are happy with where they are. They've gotten a lot more control over their symptoms. Then they come in and something's sticking out, one of those sticking out way up there, and we'll just start working on that one and figure out why that's worked. So that's a very good communication tool. And this is a picture from an actual chart, de-identified. Of course, you don't know who that is, but you can see how they're communicating very readily. The pain diagram and those pain scales. If every doctor could somehow have something like this in their office, they would learn so much more about this illness. But they don't, and electronic medical records has made it even more difficult. But you know what? You can take these in. You can take something like this in and communicate that to the provider that you meet with. But I like to use it to monitor improvement as well. And this is another one you see much more dramatic, really a lot of misery going on there, right? That's a very communicative picture. That tells you a lot about how that person's been feeling. So anyway, I want to talk about another tool. This is something doctors use in research. It's called the SF-36. It's just a questionnaire that has 36 questions. There's another version of it called the RAND-36. They're similar. The SF-36, you have to pay for it every time you use it, and the RAND-36 is a free one that doctors can get and score. But it's split into these 8 categories: physical functioning, role limitations due to your physical health, role limitations due to emotional health, general energy and fatigue or vitality, emotional well-being, social functioning, pain, and general health. So you can see the questions are kind of lumped into these different categories. And I just wanted to show you how we use this scale. This was a study we did, and the lines on top are the scores of our normal controls who were part of this study. And they did the SF-36. There are 3 lines altogether, the blue lines, so there were 3 one before they did an exercise test, 1 right after the test, and 1 7 days later. And then the dots are the score in that category. And you can see they're pretty level across the top. 100 is good and 0 is bad, right? So really severe symptoms are the low scores, and close to normal are the high scores. And you can see even the well people, can you see what their lowest score is? Vitality. That's energy. So even normal people don't rank their energy level as being 100, right? Most people are very busy, they're stressed, and their energy level's not good. But look at the chronic fatigue syndrome patients on those scores. You can see their lowest scores are the vitality scores. I'm going to go back one and let you look at those one more time. So there's, each of the scores measures a different kind of symptom. And look at the scores that are the highest and almost the same as the normal people. What are they? They're the psychiatric scores. They're the role, emotional, or the effects of your mental health on your normal role and your mental health. And you can see very clearly from a test like this that the worst problems are really the fatigue and the way the fatigue impacts what you do day to day. And tests like this can help doctors understand and sort out the differences. And there have been some studies done to show that the first one, physical fatigue, the next one, role physical, and the vitality are the most diagnostic of people with chronic fatigue syndrome. Those are the ones where they get the lowest scores because those are their more severe symptoms. Now remember that. And if you just look at the vitality score, remember that one low point across different disorders, let's compare them. So in the general population, it's about 60. In my test, in my group, it wasn't 70. So my group wasn't quite as bad as the general population. It was 70. They were younger, actually. But if you look out in the general population, most people score about 60. People with depression score about 40. People with cancer and remission score about the same as the general population. Rheumatologic diseases, about 53. Cystic fibrosis, 37, pretty bad. Look at CFS, 18 is the average. Let's look and see what our kids were. It went from 10 to 20. You see that? Because they got scored on 3 different days. And if you look at the 3 dots over the VT, you can see it's somewhere between 10 and 20. And then fibromyalgia scores the fatigue more like depression. So people who just have fibromyalgia, they have fatigue. But it's not quite the same devastating, functionally limiting fatigue as chronic fatigue syndrome. And then COPD is a lung disease, like emphysema, and then congestive heart failure. So you can see tools like that could help doctors in research and other settings understand the severity of fatigue. I wanted to mention in the talk to these mental health providers, and I'm sure it'll be interesting to you too, maybe even if you've heard this, it's kind of fun to see it again, but this is the papers that were published by Alan and Kathy Light up at the university, using gene expression to show that you can measure with a blood test the fatigue of people with chronic fatigue syndrome and with some of the other kinds of fatigue. And we started out testing people with CFS, and we sampled their blood before they exercised and then 4 times after they exercised, and analyzed the blood for gene expression markers. And we looked at 4 markers of pain and fatigue signaling in the nervous system. And we looked at markers, the ones that say adrenergic, that's your autonomic nervous system, the one that controls the orthostatic intolerance and your blood pressure and your heart rate. And then the ones on the bottom are immune markers that we see in inflammation and autoimmune diseases and infections. And we thought, well, we know these have some role, right, in people with chronic fatigue syndrome. So we're going to see what happens to them when we make them exercise, because we know people feel sicker when we make them exercise. So first we did it with normal people. And the first, where it says baseline, that's the level of all these markers before they exercise. After that, we had them exercise for 25 minutes on an exercise bike with arms and legs. And then they had their blood drawn 4 more times, 30 minutes after the exercise, 8 hours, 24 and 48 hours after the exercise. And how high those lines go up is how much change there are in those markers in their blood. And when we did it with the patients with chronic fatigue syndrome, you can see that there was a dramatic response in gene expression after the exercise. So a baseline, we called them flat. They exercised, and within 30 minutes, they're doubling, tripling, quadrupling of the gene expression related to pain and fatigue and the autonomic nervous system and the inflammatory system. This is, I think, one of the first measures of post-exertional relapse symptoms. They tested, patients with multiple sclerosis have quite severe fatigue. So they put some patients with multiple sclerosis fatigue through this protocol, and they did not have these markers. Different kind of fatigue. That's not to say they don't have important fatigue, just different fatigue than people with CFS. And they also tested it by having people exercise to exhaustion, not a mild exercise. They had them exercise till they dropped almost. And you can see that there's a little more activity, but still nothing like what happens in people with chronic fatigue syndrome after very modest, short amount of exercise. And I have to tell you that, I can show you this first. We ranked the patients according to how sick they were. I did it without looking at the results. I just know the patients, right? And so I assigned them a number, 1, 2, 3, or 4. And the ones were the sickest people who could barely get out of their house. And the 4s were people who could, they were reliable about half the time. They could take a class, they could work part-time. They weren't full-time, right? But they could pretty much depend on about half-time activity. And then we summed up all the scores on all their blood draws, and you can see that the ones had pretty high gene expression all the way down to the most well people had the shortest bars, and the most sick people had the highest bars. And I have to tell you, I couldn't get the sick people to go do this test, only 3 people. And I've tried to get more people to do it, but you explain to them what they have to do, and their eyes get about this big, right? And they say, are you kidding? I'd be dead if I did that. So we have to extrapolate the data from just a few brave souls who went to do it. And definitely they had a few people coming back for their blood draws in wheelchairs the day and two after the study. And just to illustrate it a little bit, this is just one person who went through the exercise study on the right. The one on the left are all the normal controls pulled together, and this is a 24-year-old patient of mine who's been sick for 10 years. She got sick when she was a young teenager, flu-like onset. She's able to do about 8 to 10 hours a week of work equivalent on a really flexible basis, teaching piano students in her own home. So you can see she's really, and she can do super light conditioning exercise, 3-pound weights, real slow walking for a short time. And she's, at this point she was living with the patients. Now she's married, by the way, very happy, enjoying herself. But you can see her dramatic gene expression following exercise. And these are her scores. These aren't gene expression, this is just they're telling how they feel during the study. And you can see on the bottom, these are the normal people in the study, and we are measuring physical fatigue, just asking people on the scale of 1 to 100, how bad is your fatigue, right? And so high scores are bad fatigue on this. And you can see their fatigue at baseline, and then in the middle of exercise, immediately following exercise. There's a little bit of fatigue in the normal people while they're exercising, and then it comes down immediately, not that big of a deal. And then all the lines up above are the different people we studied who had fibromyalgia and chronic fatigue syndrome. And you can see they start with a lot more fatigue, and it gets a little bit worse after they do the exercise. And the blue lines are that patient I just showed you right here. And those were her physical fatigue scores before, during, and after the exercise protocol. And here were her mental fatigue scores. And you can see there's no mental fatigue in the normal people during exercise and after exercise. And she didn't have too much mental fatigue before she did the exercise. But immediately after the exercise, the mental fatigue got worse and worse, and it's actually the worst when she came back 2 days later from doing the exercise. So it gave her brain fog to go through that exercise protocol. Another interesting thing is got 20 of my patients that are those fibromyalgia patients who do really well on the meds and were functioning pretty well on all their medications. We made them go off all their medicines. They're still cursing me for that. And go through this exercise protocol. And guess what? They look just like normal people when they did it. So pain alone is not what this gene expression is about. This is really about measuring that severe debilitating fatigue. We did find out that those fibromyalgia patients had abnormal gene expression before they even exercised. So the tall bars are the levels of those genes compared to the normal people, which are the shorter hatched bars. So we could almost, Alan and Kathy Light feel like they've devised a blood test that you can do in a fibromyalgia patient, probably show they have fibromyalgia in terms of gene expression. Now, it's not quite to the point we can do it, send you up to ARUP. That's still in the research lab. But gene expression may become a diagnostic tool to determine different kinds of fatigue, different kinds of disease processes. And I want to show you these. So they tested many, many people up in the lab, and they get these big panels of gene expression. You can buy them commercially, and you can test many, many genes all at once. Just compare them to the blood. And then what they did is picked the genes that were most predictive of the groups and create a score. So maybe the 5 scores that are most likely to be abnormal in the fibro patients, and the 5 scores that are most types of genes that are most likely to be normal in the normal patients, and total them up. And if you look at this graph right here, each dot is a person, and then their score goes up. And you can see that the cluster of fibromyalgia patients is really different than the control patients. In fact, if you draw a line across, there's hardly, at 0, there's only 1 fibro patient that falls below 0. Can you see that? And only 3 normal patients that go above 0. So that's a discriminatory test. You could actually do gene expression, just calculate the genes that are most predictive, and come up with a pretty good diagnostic biomarker for fibromyalgia. This is how you could separate fibromyalgia from major depressive disorder. They took patients who were getting ready to go have electroconvulsive therapy, ECT, really depressed people, drew their blood, and compared the gene expression to the fibromyalgia patients. And look, there's almost complete separation with that blood test. to be able to determine those kinds of fatigue. Separating fibromyalgia from chronic fatigue syndrome is a little bit difficult, right? Because a lot of our CFS patients also met fibro criteria, so we couldn't separate them quite as well. You can see there's more overlap. And separating chronic fatigue syndrome from people was difficult. These are just the blood before the exercise. There's no exercise involved here. So in order to show chronic fatigue syndrome, we had to exercise people. Drawing their blood and just comparing them to normal people before the exercise did not separate them very well. So unfortunately, we're still at the point where we have to make people sick to be able to measure that gene expression. We're hoping to get better at that. And we weren't able to separate the chronic T patients that I send up from the depressed patients, in part because I didn't screen to see if they were depressed or not. They could have been depressed when they went up, right, my chronic T patients. So this particular gene expression didn't really separate out the people with just depression from the people with chronic fatigue syndrome. But look at this one. This is the gene expression for the normal people versus the people with severe depression. There's almost 100% separation between. If you look at that -5 line, you can see there's only one person that fell below the line in the major depressive group and 3 people that are sitting right on the line. So there's really good discrimination in a blood draw between normal people and depressed people. Pretty cool, huh? Wouldn't it be nice if some years down the road we could draw blood tests and sort out the different kinds of fatigue that come from all these different problems that all present the same? So the general principles of management are, first of all, to diagnose and treat as many medical conditions as you can identify. That's the big box, right? Hypothyroidism, anemia, sleep apnea, and every time you go into a clinician's office, we're working on that. The biggest problem is they can sneak up on you later. That's when it is a little bit tricky, because if you're suffering from chronic fatigue syndrome or fibromyalgia, you just feel lousy all the time, and you don't notice when you get new lousy from something else. So you start developing a new problem. I had a patient last week who came in, been following her for a very, very long time. She said she wasn't feeling well. I examined her, and she had a very enlarged spleen. And that's, something very severe is going on with her. We're trying to figure out what it is, but many, many years after she first became sick, she's probably developed some kind of a malignancy or some kind of a problem with her bone marrow. So you have to sort of be aware and alert. These are the most treatable things. You should never miss them, right? Other medical conditions that might contribute to fatigue. Next, and this is really important, is learning how to pace your activity. I have lots of people who come in highly symptomatic because they're trying to please everyone and themselves and push through their illness. It's much, much better to learn how to pace your activity to stay out of trouble and to stay out of high symptom burden. Think about the gene expression studies. You know how those bars come up after the exercise and they haven't even begun to come down in 48 hours? So what happens if you go do the same exercise on day 2? You compound it, right? You've already got this process going on, and then you do it again. So what I tell people now when I'm teaching them to pace, I say, don't raise your bars too high and make sure your bars come down before you go do something else. And you just have to learn to listen to your body and understand that pathology that's a result of the activity. And then that's really a very important principle. And that threshold of how much you can do on any given day might change. It's sometimes a moving target. When you're doing better, you can do a little more. And when you're bad, you can hardly do anything. But you kind of have to figure out your pattern. And the last one is to address and reassess the 4 legs of the table. And maybe people have seen this before, but this is an approach to supportive management for everybody with chronic fatigue syndrome and fibromyalgia. And these are really important components that contribute to the fatigue. So the first one is mental health. I think everyone knows that if you get discouraged, if you get too anxious, if you don't have enough information, if you have poor coping skills, all those things just spiral you down. So you've got to get back on top of it, get a positive attitude, get your mood doing better, and then everything else starts to go better, and it's important. It isn't necessarily about drugs. There might be medications needed, but it could be any kind of interventions that improve emotional and resilience and mental health. The next is to address severe pain, because as we've seen from the examples of fibromyalgia patients, severe pain is extremely exhausting and draining. It's mentally exhausting, it disrupts sleep, You can't just brave through severe pain. You have to decide when the pain is enough in the background. We can't cure pain sometimes. You just have to get it to the place where you can ignore it some of the time and distract yourself. So you really have to understand it, not be afraid of it, learn non-medication interventions that help pain. I was talking to one of my patients today who talks about how she goes into a deep meditative state and can really improve her pain, learns how to relax. You can't be there all the time, but you can take a little break from your pain, and you can just distract yourself in other ways. But pain is really important to become familiar with and deal with these disorders. It's critically important to get restorative sleep. I think everybody will tell you that. There's intrinsic abnormalities of sleep in chronic fatigue syndrome and fibromyalgia. Almost no one has normal sleep that doesn't need a little help and nudge. Problems getting to sleep, problems sustaining to sleep, not getting into deep restorative sleep. Some people just don't work hard enough to stay in bed long enough to get enough block of sleep. Some people nap too much and sleep too much during the day and can't sleep at night. So working on sleep hygiene, you don't want to sleep more than your body needs. It's not that more sleep will cure you, but you need to get the right amount of restorative sleep to improve pain, to improve daytime fatigue, to restore the HPA axis dysfunction, to improve your immune function, and many other things related to sleep deprivation. So these are the major aspects. The last of the tabling in the back, the leg in the back, is about maintaining as much fitness as you can within the context of the chronic illness, because deconditioning is devastating. It just adds so much burden of fatigue and weakness, and if you stumble, you're going down instead of catching yourself to come back up when you're weak. There's just so many aspects. So it's really an art to try to find out within the confines of illness how to maintain muscle strength and flexibility and a little bit of cardiovascular fitness. And it's like I tell someone with severe insulin, brittle diabetes, or someone with heart disease, how do you learn how to exercise? Very carefully, right? You don't abandon exercise, but you have to learn to do it within the context of the chronic illness and do it in a safe way. And I just want to mention that treating the fatigue directly with medications is a little bit tricky, particularly for people with CFS. Stimulants can be very harsh. It can cause anxiety, it can disrupt sleep, and the other thing is it make you feel like you can do more than you can, and then you really crash. It's sort of fakey energy, but you still have the same consequence of the activity. People with fibro do a little better. People with mental health contributions from fatigue sometimes do better on stimulants. And sometimes you can use just a little bit just for the most important things that you want to do. But you have to be careful that you don't unravel things with trying to treat the fatigue directly. And then just to highlight this, and I really put this on here for the mental health providers, people who meet criteria for ME/CFS, the most sick people, all of it can be tremendously difficult to treat. You can't manipulate, you can't use antidepressants, it just doesn't respond to that. There's more grief work, I think, for mental health providers to work with people about their loss. I was talking to a man today, and he had mild CFS for 13 or 14 years. He could work, but he couldn't do any exercise, and he had to be really careful. And then he had a series of infections and became severely ill. He's barely able to get out of his house, can't do anything. And he's grieving. He's grieving the loss of his health. He has so many things he wants to do that he can't do now. And he realizes that he's got to learn how to walk through the stages of grief and get up and go on. Just like when you have a major loss in your life for another reason. You can't wallow in the grief forever. You've got to get back and start working on your life. So that's what I'm saying when I'm talking about mental health there. Sleep is challenging, pain is variable, and it's really, really difficult to maintain fitness with severe CFS because of the post-exertional relapse that we saw in the gene expression. So this was in the mental health providers, in the summary. Here's how you know you're making progress with interventions. Improved mental health and coping. You should be able to get rid of daytime somnolence. That should be a very treatable aspect. Should be sleepy during the day. Hopefully improve physical function with good interventions. Sometimes The fatigue itself doesn't change very much. When you're making progress, people's function improves. They can do more, but they'll do until they can't do anymore, and then they have that same level of pain and fatigue. So people come in, and their pain and fatigue scores are about the same, but instead of doing hardly anything, they're able to do quite a bit more. But they are naturally stopped by the emergence of their symptoms, and the symptoms stay kind of high. I like to see them do a little bit less, right? So the symptoms drift down and don't continue to be so haunting. But that's a personal choice. Hopefully improved cognition and better pacing. And all of those things mental health providers should be able to learn how to do. And the reason I'm talking about mental health providers, not just because this is the talk I gave to them, they're the people who can spend more time. They are the people who can sit down and strategize and talk about how to make adjustments in your life and talk about how the emotional and the physical interplay with each other. And that's why we gave this conference, is we can empower mental health providers to be a better resource, because it's really hard to get the time to go in and see physicians. And the important roles for mental health providers are to assess the component for mental health and provide emotional support that's really needed, help people move through the stages of grief and loss, help teach their patients and clients how to pace, how to learn how to do relaxation, how to distract from pain, how to cope better with sleep, learning to figure out how to do the fitness. It's a really hard process, because learning to do conditioning, it's just not intuitive. People who are good at fitness do way too much and have high expectations, and people who aren't don't know where to begin and are afraid of it because it's scary, and it could cause them pain and relapse. So it's a learning curve. And family relationships suffer with chronic illness, and therapists can play an important role in helping, kind of help with couples where one's sick and one's not, and help with parents and kids, and try to improve relationship issues. And also strategies for functioning in the workplace. It's sometimes really very, very difficult to find a way to keep working with these illnesses. And so brainstorming how to improve that is another role for mental health providers. So there's Woofy taking a nap. Put him at the end. So anyway, that's just a review of the broad aspects of fatigue, all the many dimensions, how we go about communicating it, working it up, and how we start to treat it. And I'm willing to take some questions if anybody's got some.
Are you still accepting any people in the exercise study, number one? Number two, I've read a little bit about vision issues with people with chronic fatigue, and I hear very little about it, yet it affects me severely, and I've read that 25% of people with chronic fatigue have issues with driving where it stops them sometimes or stops them completely from driving.
As in blurred vision?
Well, it's more that for me and other people I've talked to, and I haven't talked to them directly about symptoms, but their symptoms are similar to mine. Peripheral vision is altered. My judgment in terms of distance is altered. And it's not just blurred vision. It's just kind of like a fog.
That's kind of part of the fatigue, mental fatigue.
Yeah.
There are lots of aspects of vision, including blurred vision, but all those things you mentioned are present. And I think they're a little better when people are less tired. That's one setting where I suggest sometimes people try a short-acting stimulant, and some people do better when they take a little bit of Ritalin or something when they drive. They feel like they're safer and that their focus and concentration is better, that they're not distractible and they're able to drive more safely. But it's not an easy fix. And I think you have to use good judgment about whether you're safe to drive. And lots of people can't. Really. And I have young people who just don't go get their driver's license. I mean, that's unthinkable. That's like teenagers, that's all they want, right, just to go get their driver's license. I have a lot of teenagers that I have to encourage to go get their driver's license so they can kind of get out of the house, get away from their parents once in a while. But it's really challenging because it's fatiguing. It's too much going on. Yeah, it is complicated. So the answer about the study is Kathy and I might have a grant to do a lot more exercise testing. And over the next year and 18 months, they're going to be recruiting many more patients, and they're particularly interested in male patients, and because they want to make sure we get enough representation from male patients. And we also I'd like to see sicker patients go. I really would. I think that we need to understand what this gene expression looks like in the people who don't want to go do the test. They're the ones we can learn the most from. I really believe it's fairly safe to do one bout of exercise. I think you can recover. I think the most dangerous type of exercise is exercise that's sequential, right? You do it not just one time, but you do it one day and the next day and the next day, or you try to pile them up. I think when you do that, you are much more risk for developing severe relapse. I have had patients develop pain that doesn't go away, from really attempting to do too much exercise. I think the pathology of this illness is severe. I think you should listen to your body. But I can send people for a cardiac stress test, and they think they could never do it. But you can do one bout of exercise. Rest up before you do it. Go. Rest up when you're done. You can usually do it for one time. Yes, you will have consequences of it, but I think it will be consequences that will resolve. So you could probably contact Kathy Light up at the university. If you want contact information, you can call my office too, see if we could give you that information.
Thank you.
I'd love to see many more people undergo the exercise testing. The grant they have is to differentiate depression for chronic fatigue syndrome. It's going to be great because we already know they can show it. So we just now need to use the government money. They got $1 million to do it sounds like a lot of money, but it's not a lot of money when you implement all these tests. But it will be enough to get some good studies. I saw a hand somewhere. Go ahead.
Do they teach in the doctors in school about fatigue at all?
Good question. Can you hear I'll try to remember to repeat the question. He said, do they teach doctors in school, in medical school, and in medical training about fatigue? Not very much. Very, very little, because it's not a disease, and we tend to teach by disease process. So there's very little education about either chronic fatigue syndrome or fibromyalgia, in part because we don't have very good, large amounts of scientific information, and they're very conservative what they teach in medical school. They want to have a big amount of scientific data to support what they teach, and so they've kind of just left it out. So we're hoping to change that over the next while, and one of the things I try to do is go up and do guest lectures, say for the PA school or the nursing school, and go into doctors' offices. I think doctors are willing, but when it's not included in their curriculum, they have to kind of learn it as they go, and the ones who are interested will learn more than the ones who are not. I think we'll change that, but it's really under addressed in textbooks and in most curriculum. Yes.
What do you feel about cortisol studies with chronic fatigue?
Cortisol studies? You mean? Yeah.
How effective is doing the cortisol test where they test the blood at certain levels? Does that do anything with
So the question is how effective are cortisol studies? This is a very challenging area. It's a bit difficult to assess the function of the adrenal gland because it puts out different levels of hormones all day long, and you can't just draw the blood because at any given moment it's going to be changing. And it has kind of peaks in the morning and has a rhythm. And sometimes we'll try to measure a 24-hour urine collection for cortisol. And there are also some tests called stim tests, or things we do to stimulate the production and then compare it to normal. But they're a little bit tricky. And there's one test that the drug used to do the stimulation test is more expensive than is reimbursed by insurance. So no one ever does it because they'd have to subsidize it, the doctors. I tried to start doing it in my office, and I thought, no wonder nobody does this test. It won't be reimbursed, and so how can I do the test? It's a pretty expensive drug. So that's barrier number one, is it's a little bit difficult to establish the function of the adrenal gland and the cortisol. We also know from studies that people with chronic fatigue syndrome, on average, have less resilient production of cortisol, but they don't meet criteria for true adrenal insufficiency. So they're not absent cortisol, they just don't have a brisk and vigorous cortisol response. It's sort of suppressed. So if you look at the normal range, normal people fall here and people with CFS fall here. But people who have true adrenal insufficiency are much lower. And that's why we call it HPA axis dysregulation. And it's tricky because if you give someone cortisol, you suppress their adrenal function further. So if you give it to them from the outside, their own cortisol production shuts up even more. And then you're really dependent on providing it from the outside, and you can actually shut down their adrenal glands. Same is true with thyroid. And so there's a lot of people who use hormones to manipulate symptoms, but it's not lasting. So people can feel better for 2-3 months, but by the time that time has gone by and their own hormone levels have diminished, they go back to the way they were feeling, and they're stuck on the hormone. And then they either have to just stay on it, or they have to have another miserable 3 months when they go off the hormone and try to get their own to come back. So until we have much more information to understand the physiology, I've kind of avoided trying to have a quick fix using hormones. Now, if hormones are abnormal, that's different, right? If they really fall into the abnormal categories, they should be supplemented. And if someone's postmenopausal, they're gone, right? You can decide if you want to supplement them. But adrenal hormones and thyroid hormones used outside of the normal regimen become a little bit problematic. It's done widely. My own personal stance is I've become a little more conservative. I don't want to give my patient a new disease. Bad enough as it is, right? And so we go about trying to improve resilience of the HPA axis, like helping people sleep and improving mood and reducing stress, because all those things nurture the HPA axis back to better function. It's just not as rewarding as taking a pill. Harder, way harder. It's like going to physical therapy. It's slow progress, but it's still probably the way we need to go about it until we have better information, particularly about long-term safety of using hormones. Now, in a normal, healthy person, they may want to go do hormones, but the consequence to them won't be as severe, right? If they go off the hormones, they feel a little droopy, but you can put someone down with CFS by manipulating hormones that way. Yes?
My idea, or what I understood growing up pre-CFS, was that exercise was really good for me. And like being in cardiovascular shape was part of being healthy. So now that I have this, I haven't been able to, my heart feels like it's beating out of my chest, if I do too much. And I'm been trying to gradually work on this. So my question is, how important is that to, I guess, having a long life or just being in generally good health, to try and...
Yeah, exercise is important. It's just that if it doesn't work,
Well,
then you absolutely can't, right? If it makes you sicker. And I do think that we can do more than we think. Just have to do it super slowly and carefully. And it's sort of a combination of strengthening the muscles, and your heart is a muscle too. So a little bit of cardio, a little bit of aerobic. But I think the first you want to get to the point where you can function relatively normally. That's the first goal. Mm-hmm. So that going to your car, going to the store, getting up out of a chair are not a chore, right? Mm-hmm. That you can do that your muscles will permit that. That's the most important first step with conditioning, is to strengthen your muscles and have the fitness to do everyday activities. If you can make it a little more than that, that gives you a little buffer zone. So if you ever do a little more, you don't hit the wall with your conditioning. But you hit the wall pretty fast when you're deconditioned. Can't tell which one's making your heart pound, right?
Mm-hmm, yeah.
If it's your orthostatic intolerance or if it's your deconditioning. So, but I've had a couple of people tell me that they think they got well by persisting with their gradual conditioning, that it really took them to a better level.
So cardio conditioning?
No, when I say conditioning, I'm just talking about everything.
Just physical.
Keeping your muscles toned and a little bit of, the blood pumping kind of cardio. But you can only do what you can do. And you absolutely, I do not think you should do things that put you into relapse. I think that is dangerous. I think it stalls progress, and I think it stalls recovery. The more you spend in relapse, the less time you spend getting well. So you have to, that's a really important balance. And it's a changing threshold too. I think it's frustrating because some days you can do more than others. And no one can tell you very well, and you have to learn a little bit by trial and error. I gave a talk in North Dakota with a doctor who became severely ill with chronic fatigue syndrome. He was a very successful surgeon and got chronic fatigue syndrome, couldn't do anything. He could barely walk around his home. And he gave a talk with me, and he spent a long time preparing. We went to the university, and we're dual speakers about chronic fatigue syndrome. And when he finished, he almost couldn't make it out to his car. I mean, just the stress of going through that. It was a wonderful, exhilarating experience for him, but it did him in. Now, remember, someone had to help him gradually out to the car. That was a few years ago, and he emailed me this week. I realize I haven't emailed him back. And said that he's doing better, and he attributes it to really dogged, careful physical conditioning. And I firmly believe that it's helpful, but you just have to be careful, and you have to be super patient, and you've got to take into account your own level of disease, and what you've spent your energy on, and we need to learn more about it.
Is there a place in Salt Lake that supports people that journey? Because I know I was in Seattle, and I know they had a place that had a gym, and they actually dealt with people with chronic fatigue on that specific issue. And I've had trouble finding, like, I'm in physical therapy for other issues, and they keep trying to, like, I keep saying, yeah, I need this for chronic fatigue, but I don't know if they actually could use that as a diagnosis and get my insurance to cover it. Or what? But I don't
Your
think
insurance-
it's just out of their
Insurance is a little bit discriminatory. It won't cover physical therapy for deconditioning,
Yeah.
but you don't have to say that. You can list back pain, or weak legs, or falls, or painting, or whatever it is. There's lots of symptoms to pick from that you could go to physical therapy for. But insurance won't pay, and they may have limitations depending on what the prescription is for. A certain number of visits for a certain type of ailment. But I wanted to just say that one of the most important things I think that should be treated is orthostatic intolerance when you exercise. I believe that plays an important role in inability to do physical exercise. So orthostatic intolerance, that problem with the blood pressure dropping down. So I try to encourage people to do as much conditioning as possible in water, in the pool, because you're in a pressure tank. You're either horizontal in water, or you're in deep water that holds and supports your blood pressure up. You can also hydrate and do things and take medications for orthostatic intolerance before you exercise. And you can also do a lot of exercise lying down and seated. You can do many, many things in your bed or on the floor. And there's lots of things that can be done to strengthen many parts of your body without standing up. And so there are many tricks. It's my dream to have something like that. I always wanted to have a huge, big, multidisciplinary clinic with a gym and physical therapists and trainers and everything. But
One day.
money, maybe someday. Oh, go here.
I mean, that's how Pilates started.
Yeah.
In a bed, right?
Right.
With 2 people, but sorry, but I lost my train of what I was going to ask you about that. I have kind of a follow-up question, and
Well, be thinking.
now
What?
I forgot.
So there's someone you be thinking, and there were 2 of you together.
I guess I want it was a clarifying question. Are you saying everyone with CFS has an
Orthostatic intolerance.
intolerance?
We don't really know. Some people have severe orthostatic intolerance problems, and some people have less. And some people might not have any, depending on where they are in stage of illness, what other things are going on. A lot of times as people get older, they actually get hypertensive and orthostatic. So their blood pressure is high until they stand up, and then it dumps, and then it kind of comes back up. So it can be kind of complicated, and we don't have very good ways of measuring it. So I usually just use practical advice to listen to your body. If you can't stand very long, you probably have a degree of orthostatic intolerance. You can judge it by how long you could stand and do the dishes, for example, before getting fatigued, because that's not exercise, right? That's different than putting out and becoming physical. But I do think that supporting that orthostatic intolerance and keeping it in mind has helped me guide a lot of people to be able to do a little bit more physical conditioning than they otherwise would have been able to do. And the other is to do it really for short periods and to allow full recovery before you do it again. I'm going to ask the person behind you. Yeah.
When you're talking about, I guess, more severe CFS and where you talk about it gets tricky with medications, are there treatments then, medical treatments that are successful with people with more severe CFS, like aside from just your daily maintenance of what you do, like you're saying, to not like push yourself too much? Are there things outside of your diet and
Any major symptom can be moderated with interventions. So, like we were talking about the table legs, those are symptoms, right? Poor sleep and secondary depression and pain. But you have to be kind of careful with medications because medications can sometimes add layers of other problems. On the other hand, they can be saving. We use medications. They can sometimes make a huge difference in how people feel if prescribed appropriately. It's just that people with severe CFS tend to be much more sensitive to medications, and you can't just treat symptoms and make them better. You have to respect the primary problem. Fibromyalgia is more symptom-based because it has to do with the way the brain interprets pain and fatigue, and we can manipulate those neurotransmitters better. Not great, but better. So everybody's on a spectrum, and I can't tell when people walk in what they have. It's a process of experimenting and trying a little of this and trying a little of that, and that's what an individual has to do too. You push the envelope a little bit with this and with that and see where you go. And so your tolerance for activity may teach you something, or your, anyway, a medication intervention teaches me something. When I try a medication in a patient, then I know kind of where they fit, right, based on how they respond to medications. So it is a bit of trial and error, and it's very frustrating. I'm going to come over here, and then I'll come back to Linda after that.
On the subject of exercise, I had an evaluation by Stacy Stevens a few years ago, and I don't recall all the details, but I remember that one thing she said, I had abnormal results, and one thing she said was that I had to keep my heart rate below a certain level to avoid the problem, and also gradually increase the time, and that turned out to be really a key difference for me in being able to exercise.
Mm-hmm.
So now I can exercise for 20 minutes in a gym, but I have to keep my
Heart rate
like below 110, for example. Whereas if and I've gone to many physical therapists here too, and they always tell me, oh, you have to get your heart rate up higher,
Right.
you have to exercise longer, you have to push, and it doesn't matter if you feel pain and all that sort of thing, which is wrong.
All the slogans like no pain, no gain, that does not apply. And fast heart rate, I agree, signals problems. Either you're exercising too much, or there's orthostatic intolerance, the POTS is kicking in, or you're having too much pain. You've gone too far. So, and limit using heart rate, whether there's a theory that really determines the threshold of anaerobic and aerobic activity in your body, and that's a possibility. It's also just an easy way to be sure you're not exercising too hard, right? To monitor your heart rate, it keeps you from getting too ambitious. I try to counsel people. You do want to gradually increase the exercise, but you don't have to if you can. You just maintain something. So you shouldn't feel like a failure if you can't have graded exercise, harder and harder and harder exercise. You just do what you can when you can. And you're try to make sure that your body stays as strong as it can given the status of your illness. So I have a lot of respect for both ends of the spectrum. Linda.
I just wanted to make a comment about exercise and conditioning, kind of a little bit of a success story. I've tried all kinds of things to try and maintain conditioning. My exercise started out with being only able to lay down and write the capital alphabet with my feet. But that got me started thinking that there were unusual or unconventional ways to do exercise. My successful action is I exercise with a class of people who are 15 years my senior. No 30-something for me or 20-somethings. And some of the people are 20 years my senior. And the majority of exercises are done on the chair. And those that are done standing, I do what I can, and then I sit. And because of the social group that, the senior people, the elderly people that I exercise with, there's never any embarrassment about what you can do and not do. and what you can accomplish and not accomplish. And that I've been doing now for 3.5 years, except for the weeks where I'm down. I'm there a couple of times a week, and it's really been a marvelous experience.
Good. Well, thank you for that. Really, I think our time is up. There's so much we could talk about. I should just have a meeting where I just stand up here and people ask questions, and it'd be kind of fun. But anyway, I hope that this has got you thinking, maybe inspired you to sort through aspects of your fatigue and things you might have a little more control over, some things you can work on, and maybe some skills about how to communicate with your physicians and get you thinking. So more next time. Thanks for the chance to come back.